Good morning, everyone. Thanks for coming in. Thanks for joining. We've got a few more people joining. We'll get started in just a moment. Good morning. It's good to see everyone. If you want to introduce yourself in the chat, just your name and organization. We're so glad to have you join us today on this rainy Thursday. Hopefully you all are staying safe and dry. But if you want to drop your name and info in the chat, that would be great. We'll get started in just a minute. All right, good morning. I'm gonna go ahead and get us started. I'm so happy that you're here and that you're able to join successfully with connection and power. I know some folks are in some rainy spots. So I do want to be respectful of time and mindful of time so that we can um, have a good experience, but also get on our way when we're ready to go. Welcome. This is the autumn meeting of the State Epidemiological Outcomes Work Group. We're going to introduce ourselves, or excuse me, I'll introduce the team. And for those of you who are new to the group, our team is facilitated out of the Center for Drug and Health Studies at the University of Delaware. We are funded by the Delaware Department of Health and Social Services Division of Substance Abuse and Mental Health through an award from SAMHSA. We're happy to partner with DSAM on a number of different projects. This is one, and what's really a great convening of folks who are excited about behavioral health, but have a lot of knowledge to bring to the group. Today we're going to do some introductions very quickly with the team. We'll go over the goals of the SEOW. We'll talk about our new data products. We have our main presenter, which is going to be from the Delaware Delaware Violent Death Reporting System, and then we'll have some share outs. My name is MJ Scales. I facilitate this group along with Sharon Merriman Nye, Shauna Leahy, and Stephanie Ha. We are also joined today with some of our colleagues from the center. They're there physically in the building. So I want to shout out Dr. Bachman, who is the interim director of our center, Dr. O'Connell, and others who are there with them. Shauna, you want to start?
All right. So the goals of the SEOW, the State Epidemiological Outcomes Work Group, are to build monitoring and surveillance systems to identify, analyze, and profile data from state and local sources. We also identify, share, and analyze that data. We create data-guided products that inform prevention, treatment, and recovery planning and policies. And we also work to train agencies and communities in understanding, using, and presenting this data effectively. And some of our new data products. One of the first things I want to remind everyone, every 3 weeks, we do send out a little newsletter in your inbox. It includes data sources, research reports, publications that have come out, conferences or webinars, trainings that are upcoming, as well as monthly observances and other SEOW announcements. And if you're interested in getting on this listserv, if you are not on this listserv already, you can leave your email in the chat. I'm sure MJ would be happy to add you to the listserv for that. So that comes every 3 weeks into your inbox. We also have recently completed an opioid infographic series. Some of the topics that included were health consequences of long-term opioid use, the effects of opioid use during pregnancy, opioids in older adults, as well as opioids in treatment, with a little shout out about harm reduction in that. And then other exciting news, the 2025 Epi Report and all associated products are available now. We will link the website for that in the chat. So that includes the executive summary, the companion guide, the slide deck with included figures, and then also all 12 chapters and infographics that include topics, indicators of mental health and well-being, patterns of substance use and its consequences, and risk and protective factors. So that is all available on our website as of today. And we hope that you check all of those out. And that link will also be included in a link sheet we send out following the meeting.
Thanks, Shauna. The one thing I want to call attention to with the Epi report, first I want to give a shout out to the IT team at the university, because they've quickly turned around these products for us and posted them. Usually there's a longer time, but I'm really very excited that the products are all now available 2025 on our website. The one thing I mentioned in February, and want to highlight again here, is that there was this change across the board and across the country of data availability at the federal level, whether it's not available at all, whether it's available only in certain pockets. And so if you have questions as you're looking over the Epi products and you're like, hey, this wasn't like this last year, or hey, is this information available in a different way, feel free to reach out to me. I'll put my email in the chat and we can have a longer, more robust conversation about it. A lot of the data was available, but some of it had to be done in a different way. So shout out again to the team, including Emily Ralph, for their hard work in pulling this together. Again, if you have any questions, let me know. I'll put my email in the chat. All right, so before we get into the data, one thing I want to talk about is we are going to talk about a topic that is challenging, right? So today we're going to, our main presenter is from Delaware, division. Why am I struggling with this, y'all? The Violent Death Reporting System. But one thing I want to share with you is that this is a difficult topic, right? And I want everyone to practice good self-care as we're talking about these things. We're coming at this from a data-driven perspective, a data-informed perspective. And we're going to talk about data, but we're also talking about people. And so it's important that you take a moment. You know, if you need to step out or step away from the screen, please do so. If you need to be connected with resources yourselves, please reach out and we're happy to do that. We want to support you as we're talking about a topic that can be potentially difficult for folks who have been touched by suicide, who have been, be survivors of attempts. So we just want to be sensitive and hold space for folks and the impact that this information may have on you. We want to start to lay the groundwork on the topic to talk a little bit about some suicide statistics in Delaware. These numbers are from the 2023 YRBS. Middle school students reported that at some point in their lifetime, this is 2023, 21% thought seriously about killing themselves, 15% made a suicide plan, and 9% attempted suicide. When we look at high school students in the past year, 17% thought seriously about killing themselves, 14% made a suicide plan, and 10% attempted suicide. when we look deeper at that number, right, we know that when we report totals, oftentimes the total doesn't tell the whole story. When we look deeper, we know that certain groups experience certain things at different rates, right? And in this data is no different. Female students and students who identify as lesbian, gay, or bisexual are more likely to report seriously consider suicide, planning suicide, or attempting suicide compared to male students and compared to heterosexual students. These slides, the SEOW slides will be available. This information also is in the Epi Report products that we discussed. So, I don't want you to scramble to write these things down, but we'll make available for you after that. And when we talk about suicide, we also have to talk about the impact on families and communities. So about 1 in 4 eighth graders in the Delaware school survey in 2024, and about 1 in 3 11th graders lived with someone with mental illness, depression, or who was suicidal. And we know that that's one of the ACEs that has that can have an impact on people's lifelong well-being. And when we talk about suicide broadly for the state, since 2019, there have been more deaths in Delaware by suicide than homicide. And in 2024, there were 132 suicide deaths, double the number of homicides, which was 66. And more than half of those suicide deaths involve the use of a firearm. So we are in some ways talking about a public safety issue, as well as a public health issue, as well as a behavioral health issue. And so that's why it's important that we have folks around the table from a variety of different backgrounds, perspectives, and trainings to, coalesce around the issue and see how we can prevent suicide from impacting individuals, families, and communities. So again, this information, I know that was a quick blow through with the data. It is available for you in the Epi report. It is available online. A lot of this data is available online, specifically the YRBS is available for you. The Division of Forensic Science 2024 annual report is also available. So I just wanted us to get kind of, as we go into the main presentation topic, get a sense of the scope of how this impacts young people in Delaware and families in Delaware. Sharon?
Good morning, and thank you, MJ, for the overview. I'm so happy to see so many folks here today, especially folks who are here that haven't been members before. But we do have a number of folks here from the Delaware Suicide Prevention Coalition, the Coalition for a Safer Delaware, as well as a number of folks that have been coming to these meetings for quite some time. I just wanted to mention that the Delaware Suicide Prevention Coalition has been in existence since 2004, and its goal is to raise awareness that suicide is in fact a preventable public health issue, and that it works to create the behavioral and social changes necessary to reduce suicidal ideation and attempts. We have Sydney Elliott here today, who is the contact person and coordinator for the coalition, and I've included her email address in the slide. So if anyone wants to get in touch with her, please feel free to do that. Something very exciting in the state is that in August of 2025, Delaware established an Office of Suicide Prevention when House Bill 54 was signed into legislation. I think that we're going to be hearing news about the office as time unfolds, and I just wanted to include the link in there as well for that legislation, along with a link to the governor's press release. I'm now going to turn our attention to our guest speakers. For some of you that have been participating for a long time in the SEOW, you may recall that I believe it was in 2019, we had one of our featured speakers, Amanda Bundick, came and talked to us about the data that was being entered into the violent death reporting system related to overdose deaths. Today, we're fortunate to have both Carolyn Judd and Amanda Bundick presenting today from, again, on the data source of the violent death reporting system, which they both lead this initiative, and they're going to be reporting on the topic of suicide deaths in the state. I'm going to give you a little background on each of our speakers. Carolyn Judd is an MPH, an experienced public health professional with a strong background in epidemiology, data analysis, and program coordination. She is serving as an epidemiologist 3 for the state of Delaware and leads the statewide surveillance projects on violent death and drug overdoses, offering high-level data consultation and public health strategy development. With over 15 years of experience, Carolyn has held key roles in both environmental health and infectious disease response, including leading COVID-19 epidemiology field operations and overseeing large-scale food safety initiatives. She has a Master's of Public Health and Epidemiology from Tulane University and a Bachelor of Science in Health Policy and Administration from Penn State. Carolyn is also a published researcher, contributing to peer-reviewed literature on rapid hepatitis C screening in high-risk populations. Her work reflects a commitment to using data-driven solutions to address complex public health challenges and improve health systems and outcomes. Amanda Bundick is a public health epidemiologist and first responder with over 20 years experience dedicated to improving community health and life safety. She currently serves as an epidemiologist 2 for the state and the Division of Public Health, managing violent death data and leading analysis and outreach through the CDC's National Violent Death Reporting System. Amanda is also a longtime volunteer firefighter, EMT, and instructor, holding leadership roles in both the Little Creek Fire Company and American Legion Ambulance Station 64. Her work spans outbreak investigations, public speaking, data analysis, and program development. She has presented on death education and resilience for frontline death workers to diverse audiences on multiple occasions. Amanda holds a Master's of Science in Thanatology from Marian University and a BS in Biochemistry from Virginia Tech. She brings a unique multidisciplinary perspective to emergency response, data-driven public health, and death and resilience education. And we are very fortunate to have these folks here today to talk about this topic. So I'm going to turn it over to you, Carolyn and Amanda.
Thank you so much. I just want to say, first of all, we've had a power outage this morning. So if both Mandy and I just disappear randomly, it's just the power. And the rain is starting. So we don't know how this is going to play out. But thank you so much for having us. I think what we're going to do is Mandy's going to talk first because she has some pretty exciting information from an infographic to dive into a little bit. And I do have slides from a previous presentation on suicide circumstances from DVDRS, but I also have some non-fatal suicide data. So I wasn't sure entirely how much you wanted me to get into both of those, but I do have both of those presentations available. So we can let Mandy go first. And if y'all want me to keep going into some other data that's available, definitely let me know.
Thank you, ma'am. Would you mind, or either one of you, as you start off? I know I was fascinated from your presentation years ago about this circumstances. For those who are maybe are not familiar with it, if that's not already part of your presentation, would you share with folks what that is?
Sure, I'm gonna. Sorry, Caroline. I'm gonna touch on it as I go through my presentation. So I'm gonna start kind of and lay the groundwork, and then we can, if Caroline wants to look at the circumstances, we can do that, and also look at some other, I think, non-fatal data that we have as well. So let me try. We're gonna share the screen. Here we go. And can everybody see it? I'm hoping. Share. Yay. We're screen sharing. All right, good. All right, and then let me try slide showing. And do you guys see my slideshow?
Yes, ma'am.
All right, good. All right, cool. Okay, so little introduction. Thank you. I forgot how wordy my bio was. It felt very weird. So I'm Mandy Bundick. My professional name is Amanda, but I go by Mandy. I am the violent death epidemiologist for the state of Delaware. I've been doing this since 2017. We started collecting data in the second half of 2016. So I've pretty much been here since the inception of our program here in Delaware. I'm very passionate about death. In a good way, in the best way possible. So please excuse me if I seem really animated and I talk with my hands a lot. So let's dive into it a little bit. So what I'm going to kind of do is I'm going to start out and we're going to talk about what our firearms death look like here, because that is of course concern, what our suicides look like, how we compare nationwide. And then I'm going to get a little bit into our infographic, which is very high level about DVDRS, couple little nuggets that I'll pull out for you. And then we can go to Caroline, who can give you a little bit more. We like to tag team in our roadshow. So when I presented in 2019, I remember she wasn't able to go. So I did present some of that data without her because we had been doing some road showing together. So we're definitely a little dynamic duo together. So I'm happy that we're doing this. So let's get into our firearm deaths. So for the state of Delaware from 2023, this information is from the CDC. We rank 39th overall in firearm deaths. So that's going to include our homicides, our suicides, your accidental firearms, which we don't have many of, but that's where we are in the United States as a whole from 2023. And I believe that this information comes from the Health Statistics Center. It comes from, our death certificate information, as opposed to what I do for DVDRS. And I'll give you guys a little disclaimer about our differences. So as you can see, 39th overall, we don't particularly have the most, but that's 124 firearm deaths that perhaps could have been preventable, could have been redirected somewhere else. So it is definitely a concern because that's 124 Delawareans who are no longer with us. So let's see how that breaks down within our homicides and suicides. So homicide, we do rank 28th. We had 55 homicides in 2023. Once again, we don't particularly have the highest number of homicides, but for our population, it is concerning. And I think when we talk to other states and when we talk to folks, it's hard to think about, when you're talking to other states who may have hundreds of homicides, it seems like we have a very small burden, quote unquote, because we only have 55. But I feel like we need to also take a moment and take a step and remember that that's 55 people who are no longer with us, and that we need to remember that. And it's still just as concerning as if we had 550. So I think that we just definitely need to make sure that we are cognizant of the fact that that is 55 people who were related to somebody else that were important in this world. And that homicide number also, when we're talking about firearms versus homicide, not all homicides are firearms related. So, and I'll show you a little bit about that with our data as well. And now we're going to jump to suicide. 42nd in suicide, once again, 140 suicides in 2023. This is the information that we got from the CDC. This is definitely not the most. There's a lot of states that have a lot more, but once again, this is a number that I think that we can work on and look at being, getting down, that there's definitely something that we can use the circumstance data that we do collect and look at ways that maybe we can give that data out and we can look at prevention and all those sorts of things. Once again, 42nd, it doesn't seem like we're really high up there, but still, I would like that number to be closer to 0, even though it might mean I'm out of a job, but that's okay. That's how I end up out of a job. I'm okay with it. That's 144 people who could still be here. Moving on. So this is my baby. This is what I'm very excited to talk about. So what is the Delaware Violent Death Reporting System? We collect detailed information on the violent deaths that occur in Delaware, including homicide, suicide, unintentional firearm, legal intervention, and deaths of an undetermined intent. So I think homicide and suicide and even unintentional firearm are very easy to understand. Unintentional firearm would be like celebratory firing, or if somebody was accidentally discharged their firearm while they were cleaning their weapon, or a hunting accident, something along those lines where there was no intent, or the intent wasn't able to be defined. So that is your accidental, your unintentional firearm. Legal intervention is a definition that we as abstractors within the system put on a case. The manner of death coming from the ME's office is going to fall into a few categories: homicide, suicide, undetermined, accidental, or natural. So a lot of times these legal intervention deaths are going to be called homicide by the ME's office, but we as abstractors, as we read through it, we understand that the actions of a law enforcement officer resulted in the death of the victim. So this would be, most commonly we see it as a police-involved shooting. This can also include motor vehicle accidents where a victim or a suspect, depending on your police jargon you want to use, I use the term victim because if they died as a result of being chased by the police and they were running because they had a warrant or for some other reason, that is actually considered a legal intervention death as well. And that would fall under our jurisdiction, and we would mark it that way. And I would look at it. And then we do look at deaths of undetermined intent that have a known weapon, which means that we know what the cause of death is. So the best way to think about this is if somebody has fallen from height and we're unsure if they were pushed, if they tripped and fell, or if they did it on purpose. So any of those deaths where we're not able to determine the intent, because there's two parts in the death certificate. There's the manner, which is where the intent is, and then there is the cause of death, which is actually the injuries that caused the death itself. So we do look at both of those things when we're going through them. And we collect this information on victims fatally injured in Delaware. So this is a very important caveat to remember with our data. Our data is collected on victims who are injured here. It does not matter where their residence location is, and it does not matter where they die. If they are injured here and they're transported to a hospital outside of the state of Delaware, it is considered our violent death because we're looking at where the injury occurred, because that's where the circumstances matter the most. And that's where the prevention or the intervention could have occurred, where the fatal incident is inflicted, as opposed to where they die. So that kind of means that sometimes our numbers will always match everything else you see because we collect our data a little differently. And we're collecting that data from our death certificates. We're collecting from medical examiner reports and law enforcement reports. And in addition to that, we have just added for 2025, we will be looking at Deemer's reports, which is our EMS reporting system. Because as an EMS provider myself, I know a lot of times victims, families, witnesses may say something to us as EMS providers that they're not going to say to police because of just depending on the situation. A lot of times a family might be more forthcoming with us as medical providers as opposed to a police officer who's there in a different capacity. And also with stigmatism and some other things, a lot of times they feel more comfortable talking to emergency providers as opposed to police in those situations. So that's something that we can definitely look at. This is my little, disclaimer with all of my information, just to make sure that we are supported by funds from the CDC, and just know that they're not, anything that I say is not an official representation or endorsement of any of those entities. This is kind of our stuff here, but just want to have it in there just so you know that I'm all above board. Next, we're going to talk about, so this is a little bit of background. Does anybody have any questions? I haven't been looking at the chat, so I apologize for that.
There were a couple of items that came in the chat, and I tried to answer them as we went. But I think there's just clarifications about the rates and comparisons in the different states. How are they ranked? And it's by the rate, not a count. And another question came in about somebody being injured in another location or another state. Mm-hmm. It's not captured in our data system. It will be captured in theirs. So it is solely based on injury location, not residence or death location.
Correct. So we get some people, because of our location of Christiana Hospital and the trauma center there, we do get people who are transported to Christiana because that is the highest level of care, the closest highest level of care. So we do get people who come from New Jersey, from Pennsylvania, and from Maryland, who may have been injured in other states. And we do communicate with the other states and share that data back, because they will go to our ME's office, but they were injured in New Jersey. So we take care of kind of abstracting the data for them on our side, and then we forward it to them so they can have that for their side. So we have a very good relationship with Maryland and a very good relationship with New Jersey, where we're on top of it and we share things. And similarly, if we have, especially down at the beach, a lot of people will end up going over the line to Maryland, and Maryland sends us those cases back. So we do share that data across state, if allowable by the state. Not every state is able to do that, but fortunately for us, New Jersey and Maryland are able to share with us. So it's very helpful for us to have the complete picture of what's going on in our state, from a fatal injury standpoint for these violent deaths. So because we have been doing this finally for so long, we've been doing this since 2017. I am very excited. Just a little also background. I think I forgot to mention. So our closeout on data is 16 months after the end of the year, because a lot of states do not have the centralized systems we do. We are very fortunate in the state of Delaware. We have Delgis, where we can go one-stop shopping and get all the police reports. Other states have to go to each individual law enforcement entity to get their data, which is time consuming. It's a travel, it's communication. We have one-stop shopping. We go into Delgis, we're able to get that. Now we have to be background checked, fingerprinted. There's a lot of things that go into that. We're highly tracked on our use of Delgis. So it comes with all of those sorts of things as well. We also have access to the medical examiner data. We are very, very, very fortunate to have a centralized system. We are not a coroner system. Our medical examiners are death investigators. Everybody at the ME's office, they're wonderful. Our police write really great reports. So we are very fortunate in the state that we are able to access this data in pretty much real time and get that data. With that being said, other states, since they have to collect this and investigations take time, there is a 16-month lag from the time that the year ends until the data closes out. So our 2024 data actually doesn't close out until April of 2026 at the end of the month. So that's why you're going to see when I present the data, there's a little bit of lag. And also, because of our small numbers, we have to aggregate over 5 years because we just don't have the numbers, which once again, everybody's like, oh, well, you guys have small numbers, but still it's lives lost. And that's not anything we want to see. We're in public health. We're here to keep people healthy, not to, not the other way and be like, oh, well, we only had X amount. We want to get that number down as much as we can. So in order to kind of talk about what we look like for our first 5 years, oh, there we go. This is, it's very small here, and I understand that, but we can send this out to you guys, and we will make sure you guys can have a copy of it. But this is an infographic that I worked on and got approved and everything this summer. So this is basically a 5-year snapshot of Delaware and what we're looking at. It's very high level, explains about our violent death reporting system, and it's something that has quick and easy data that we can pull out and a little bit of our circumstance data. So the first thing I'm going to talk about is just this is what it is. So for our program for 2017 to 2021, we had 605 suicide victims and 341 homicide victims. We also had some undetermined cases, some legal intervention, and an unintentional firearm. And this is kind of the breakdown over those 5 years. It's pretty standard. We typically, like I said, I've been doing this. We typically have more suicide than homicides here in the state of Delaware. It's just our breakdown and the way it is. Everything that you see here is nothing that's outside of the ordinary compared to other states as well. I think we all kind of see the same sorts of trends from state to state overall. So, all right, moving on. So this is what we wanted to talk about. This is why we came here today. This is the best part of what I do. We collect circumstances for every victim. We collect 665 data points on every victim of violent death in the violent death reporting system. Sometimes we collect a little bit more depending on if they're a public safety officer, if it was related, if it happened in a school, we do have some extra stuff that we do collect. But this is what we do. We look at each victim and the circumstances that occurred prior and during, right around their death. So kind of perimortem, antemortem, nothing really postmortem, but we're looking at what went on and what led to kind of to this incident occurring. So as you can see for suicide victims, very often they endorsed a depressed mood. This is different than depression. Depression is a medical diagnosis. A depressed mood is we're looking for keywords. So as abstractors, we have a very thick manual, and there's these keywords that we're looking for that are descriptors within the ME record or the law enforcement record where the person was sad, despondent, blue, all of these things that maybe they were just experiencing a high level of sadness or they were depressed. If one of their friends said that they were depressed, but they weren't diagnosed with depression, this is what we endorse: depressed mood. If the person was angry or enraged or anything like that, we do not endorse that variable. It's very specific to the person was experiencing some sort of sadness, depressed mood, blue, had things weren't going their way, something of that nature. And we have these keywords that kind of trigger that. A mental health diagnosis is frequently noted as well. That can be anything from ADHD to depression to bipolar to schizophrenic, schizotypal, Alzheimer's, dementia. We do look at all of these things. Those are endorsable. Autism. We do look at all of those sorts of things within a mental health diagnosis. We also collect if the person was currently in treatment or if they've ever been treated, and if they're kind of compliant with their treatment at that time as well. A suicide thought history. So this is anybody who's expressed suicidal thoughts at some point in time, and that is noted in one of our data sources. And if they left a suicide note, which most often we do see noted in the police will write that in there. And then a lot of times it'll be in the ME record as well. So these are some of our more frequently noted circumstances overall. This is across all of our suicide victims. Now, if Caroline presents on we can kind of pull things out and tease things out, looking at different groups. But overall, this is what it looks like in Delaware. Just to note, circumstance variables are not mutually exclusive. So one victim could have several circumstances noted. So they could have a depressed mood, a mental health diagnosis, a suicide thought history, and leave a suicide note. So that's also another thing to remember, is that, sometimes we get all this really rich information, and sometimes we don't have any information at all. There are sometimes cases where I'm just reading through, and there's really no circumstances that we can glean out from the information. That's why we're very excited to have access to the EMS reports, because in the EMS reporting, we can also look back to see if they had prior contact, because we collect data around prior contact with authorities. So if the victim was known to authorities, meaning that they had been picked up by EMS, they've been to the police, something along those lines. So having that access to the EMS data is going to give us another way that we can see, did they interact with the system, and is there a chance that maybe something was known prior to the incident. On the flip side of that, we have our homicide victims. Our homicide victims most frequently have an argument. So that means that either the injury occurred during the argument, or after, or sometime after the argument. There was drug involvement, meaning drug trade. There was some sort of money exchange going, drug buy gone bad, retaliatory. There was drug involvement in some way related to another crime. Sometimes this is drug involvement, sometimes this is robbery, sometimes this is carjacking. There's a myriad of things that we kind of collect around this related to other crime. And then the fourth most kind of frequently thing that we see is physical fight. So individuals engaged in a physical fight, in either the actions, personal weapons, or a firearm, leads to the incident and the violent death. And once again, we can have the victim may have multiple circumstances noted. And I will say, I have been doing this since 2017, and the homicides by far are a lot harder to glean out all of the circumstances, because homicide is there's so many different things that can go into a homicide versus the suicide. There seems to be, it's a little bit easier sometimes to glean those circumstances out than there is for the homicide, because at times the homicide, there's no witnesses. It's not known. Sometimes it's just the shot spotter notification and a body is found on the street. So the police really work hard to try to solve these crimes, and we check, and we're always checking back to see if we can find some circumstances. And we do abide by, if it's not written down, it didn't happen. So our part-time abstractor, Melissa Jarman, is a career EMT, so she's on the street as well. And we do have a lot of contacts with law enforcement. And we do come by information. I have family members who are detectives and police officers, and they may say something offhand about a case. And I'm like, well, if you didn't put it in the report, I can't do anything about it. So that's kind of where we're looking at, as well as if it doesn't get written down, it didn't really happen. So we really do make sure that our data quality is the best it can be by abiding by that we can go back into a report and pick something up. Melissa and I also abstract. So if I'm abstracting the law enforcement on a case, Melissa will abstract the ME information. And we do that in order to make sure that we're not bringing some bias over from one part of the case to the other. And that seems to really improve our completeness and our data quality, because we're both looking at it with fresh eyes. So that definitely has really helped our robustness of our data. And of note, just because I like to brag about this, we are ranked 10th in data quality and completeness out of all 52 programs in the NVDRS program. So we are ranked 10th overall for everything, which is a really big deal for us because we are one of the newer states. So we always get really excited, and it's much love to Melissa for helping keep me straight, and much love to Caroline for being an awesome principal investigator. So I think we have a really good system here in Delaware that keeps us with good data. So we're very fortunate to have the systems that we do. I'm going to move on now.
I was
Yeah.
just going to say, before you move on, there was one question about the drug involvement circumstance.
Okay.
There was a question to clarify, does it include, I believe, the victim being under the influence of a substance at the time of the death? Oh, either the perpetrator or the victim.
No, so drug involvement definitely means that it's drug trade is involved as opposed to the person being intoxicated. So we will endorse if we think it's alcohol involved. That's a separate endorsement tab. If they're under the influence of a substance, we would see that in the toxicology. And we would check off, there's personal, not necessarily for the suspect, but there is suspect variables if they were, I believe, if they were under the influence or if they were having some other issues. And then for the victim, if they had substance abuse history, we would put that in there. And then we would also note it in the narrative if somebody was under the influence of drugs or alcohol. We will say that, you know, the toxicology was positive for X, Y, or Z, or they recently used prior to the altercation, or, you know, they were suspected of using illicit substances prior to the altercation. But that drug involvement is specifically drug trade, as in the, you know, money changing hands or stash house, something along those lines.
And then there's further clarification. Does it include being under the influence of alcohol? So not the drug involvement, but if there is tox, does it include alcohol?
Yes. So our toxicology does, the standard toxicology panel covers, I think, about 12 or 13 classes of drugs. And then they also, which they run an ELISA test for, and then they run a GCFID, which is the gold standard for alcohol. And then they will pick that up off of that. And then we do have a separate circumstance that we can endorse that if we think there was alcohol involved in the situation or not. But we can also pull the tox report if they were positive. I hope that answers the question.
I think
Okay.
so. There was another comment that was about something about things being highlighted, but they get blacked out. I don't know what that's about. But it might be in the law enforcement reporting, how maybe certain things get redacted, unless I'm misunderstanding the comment. I'm not sure, but we can move on if you want.
Okay, yeah, we can address that. I wonder if it was the same issue I was having, which was like my screen was up, but then there was like a bar across something. So I'm not sure what was going on with that. It was like a visual thing that I saw. But
Yeah, I don't know if it's technical to the presentation or to the content. So, okay, we'll keep moving.
So lastly, on kind of on my wonderful, beautiful infographic, here is our 5-year snapshot of our weapons in our homicide and suicide. So this goes back to what I started with, which we were looking at our firearm deaths overall and then homicide and suicide. So here's our breakdown of firearms, sharp instruments, of our weapons by our death type. So your suicides, as you can see, in the state of Delaware from DVDRS, once again, this is from our DVDRS data. So that is a little different than what you're going to get from the medical examiners because we do look at things a little differently. 83.3% in this 5-year period utilized a firearm to die by suicide. You can see the homicide is 46.4%. We have sharp instrument, which I think is pretty self-explanatory. Hanging, strangulation, suffocation. Poisoning, which includes carbon monoxide. So carbon monoxide is poisoning. So if somebody uses that in order to die by suicide, that would fall under the poisoning category. And then our other weapons, that includes personal weapons, so fists, other transportation, so train tracks, motor vehicle, intentional neglect, fire, falls, drowning, and blunt instruments. So that other weapon category kind of is a catch-all for everything else that we can tease out. But overall, within this 5-year snapshot, they kind of we weren't able to tease them out just because of the smaller numbers on those. Of note, somebody can have more than one weapon type. I have had folks who have used two different types of firearms, used a firearm and a sharp instrument, strangulation and a sharp instrument. So there's a myriad of ways that folks utilize weapons for violence against themselves and against others. And I think that this is the highlight. We were talking about the firearm that goes back to the beginning, but also Caroline and I recently attended a community violence intervention summit at DSU a few weeks ago. In one of the speakers, we were talking about, that idea of, having impulse and access to a firearm seems to really be that moment, that moment of change, of what can change a life very quickly. Is you have this impulse, and then if you have the access to the firearm, that, sometimes violence can come from that. So I think that that's an important thing for us to think about. And I don't think anybody here would argue that is like anything different. You got impulse, you've got access to a firearm, bad things could happen. You could definitely alter your life or someone else's life at that moment. So that is something to be cognizant of and moving forward. But this is the sort of data that I do have available in the violent death reporting system. We do collect weapon type for the firearms. We do collect whether it's a handgun, a shotgun, a rifle, make and model, who owned the weapon, where was it stored loaded, and all that information comes from the police report. And the EMS will also be able to give us some of that, because we will write things down if we see them when we're there. And that is if it's available to us, we do report that out. So hopefully that was helpful, and hopefully moving forward, we can share this with folks as needed. And that's the end for me. That's just our little snippet of Delaware Violent Death Reporting System. As I said before, I'm very excited to share this data, to be able to start looking at this data in a meaningful way. The circumstances are so rich and so varied and so nuanced. And I think that there's just so many ways that we can look at this data and use it and put it out and think about it moving forward in order to really, impact lives here in Delaware in a positive way. So does anybody have any questions before I give it over to Caroline?
Well, I can read the comment as well that came in. Tracy was at the summit as well, and she was saying that was probably her who brought up the impulsivity discussion. And I apologize if I had realized I would have come up and introduced myself, or finally got to meet in person, because I know we've been on a couple of calls together, so it would have been great to touch base. But also, I did want to point out, I think, Tracy, it was you that posted that there is, I don't want to say a summit, but there's an event on November 17th at Christiana Care. So that looks amazing. So Mandy and I think are going to touch base after this and see what our availability is for that. But also, if you'd like to use the infographic, it is publicly available. We can send it out after this call, so you have the document and use it however you see fit. It's a public document for anybody to use however they'd like to. But I did see other people coming off mute, so I don't want to take over the chat.
And I'm going to stop sharing my screen now, because Caroline will have the same. If the data requests, and if you need to contact myself or Caroline, please don't hesitate to reach out to us.
Ms. Judd, I think you're good to keep moving.
Okay, so I will dive into the slide deck. That is something that was presented at the Delaware Suicide Prevention Coalition in 2024. So it's about a year old, and I haven't looked at it in quite a while. So this is kind of like a little bit of a trip back in time for me. But I think it's important to look at these data. It was kind of the precursor to Mandy's infographic, and realizing we needed to take a step back and sort of describe what DVDRS is to everybody and kind of get people more familiarized with the fact that this data set exists. But I think moving forward, we're going to try to pull the data that I'm about to present into more of a suicide specific infographic. And we haven't done a similar type of analysis for homicide yet, but we're thinking of doing something similar on that front as well. So Mandy, if stuff comes into the chat, I don't know if I will be able to see it. So if you can help me out, that would be really cool.
I'll do my best to.
Okay. And I will see if this is actually going to work. Oh, so now, okay, my monitor is showing everything. All right, let's go into, oh, no.
No, it's good. You're good.
I'm good. Okay, because
Yeah,
I
looks good.
lost everybody that I was talking with. Okay, so I'm going to go through this pretty quickly because Mandy covered a lot of the background information, because this is based off of DBDRS, the disclaimer that we have, the data that are contained in it, how many suicides we're looking at, and we had 98% coverage of circumstances available, 98% availability of information on circumstances for our suicides. And this is similar to what Mandy was presenting in the infographic that she made, just an overview of the top circumstances that we see in suicides. So I'm going to move ahead, and how many that we see, it's mostly 5 to 8. So like she was saying, there can be more than one circumstance per suicide. And this is also something that she covered with the type of mechanism. But this was a little bit different in that we were trying to figure out some of the different populations of interest that kind of come up in a lot of conversations with the Delaware Suicide Prevention Coalition, or that we talk about with different mechanisms. You know, we wanted to break it down a little bit in a way that works for our small numbers and see what is really significant when breaking them down. So in looking at this sort of middle-aged population, the 25 to 64-year-old population, from 2017 to 2021, firearm wasn't really the mechanism. It was in people who were not of Black race, not military history. Their education was high school or more, compared to no high school or less than high school education. And they were more significantly divorced. And this isn't to say that those other types of demographics didn't exist. This is just more likely. This is more likely what they were going to look like. And then the significant circumstances, they were more likely to have a mental health problem, to currently be in mental health treatment, to have an intimate partner problem, have a suicide attempt history, and no documentation of a physical health problem within the systems that we review.
Hey, Caroline, I just wanted to, on the intimate partner problem, this is different than intimate partner violence. An intimate partner problem, I just like to give a little context since we're able to dive a little deeper in with guys. Sorry, I didn't mean to interrupt you, but intimate partner problem is they were having an issue with a current or former intimate partner. This includes, they broke up, they just got back together. There was something going on in the situation. So a lot of times if they're having an argument with their intimate partner, we would also endorse intimate partner problem because they're having an argument with somebody. So those are two circumstances a lot of times that we see together, if that is indeed what has occurred. But it's different than intimate partner violence, which we see in homicide. Intimate partner problem is pretty much what we own. That's a suicide specific within the system circumstance. Sorry, I didn't mean to interrupt.
Not at all. I'm glad for the clarification. But I am going to keep moving. So within the population 65 years of age and older, we saw more significantly a firearm mechanism, white race, military history, residence in Newcastle County or Sussex County, and having a rural zip code or being married. The circumstances that were significant were having a substance and or alcohol use history, no note of a mental health problem, no note of suicidal thought history in medical records that we have access to, not being on current mental health treatment, no notes of having an intimate partner problem, and no history of suicide attempts. But what was significant was having a physical health problem. And there we go. For decedents under the age of 25, we saw more likely for them to have a mechanism of hanging, strangulation, or suffocation, as opposed to any other mechanism. More likely to be of Black race, have a military history. And that might seem kind of weird because you might think of veterans, maybe even older age population, but this is about military history. We define it a little bit differently. So it's any kind of military interaction, not necessarily just veterans, because I know that's sort of a category that a lot of people like to focus on as well. They're more likely to be in Kent and Newcastle counties, they're younger, you know, it's maybe that they're more likely to have gone through more education. And similarly, less life experience, they're more likely to have never been married. Significant circumstance variables are that there's no documented substance and or alcohol use history. And similarly, they haven't had a documented physical health problem. And then we like to focus on age a lot as categories, but like I said, we do want to talk about military history as its own unique category. And the things that were significant within this group included firearm mechanism, being of male sex, age 65 or older, being in Kent County or living in Kent County, having less than high school education, and being married. And there are significant circumstance variables, are substance and alcohol use history, and having a physical health problem. And then to kind of shift again, I wanted to look within just the firearm suicide decedent population. And you can see the tie-ins to the other breakdowns of populations, but it's just a different perspective. They're more likely to be male, age 65 or older, have a military history, live in Kent or Sussex County, have a high school education, and to be married. Their significant circumstance variables include having a documented mental health problem, not necessarily a mental health diagnosis, being on current mental health treatment, history of having a suicide attempt or attempts, and having a physical health problem. From the perspective of the hanging, strangulation, suffocation, suicide decedents, for the next mechanism, the next most prevalent mechanism, they're more likely to be under the age of 25, not have military history, live in Sussex County, have less than a high school education, and to never have gotten married. The circumstances that are significant are having a history of suicide attempts and not having a physical health problem. From the poisoning perspective, and like Mandy said, this includes not just like illicit drug overdose and intentional drug overdose, it does include carbon monoxide poisoning. And in this population, the decedents are more likely to be female sex, age 55 to 64 years old, and their circumstances are more likely or more significant. Those are mental health problem, being in current mental health treatment, and having a history of suicide attempts. And in, gun ownership and firearm mechanism is definitely a very, important piece of this whole conversation, very much of interest for a lot of people. So I wanted to present something from that perspective. Well, actually, it was Mandy that really identified this. This is something that she really sees in the data. But when you look at the firearm suicide deaths, and if the firearm was owned by the victim, the decedents that were of male sex, white race, military history, age 65 or older, they were the ones who were more likely to own their own firearm. That was the mechanism for their suicide death. And they also had a significant circumstance variable of being currently in mental health treatment at the time of their suicide. And just a little bit of like overlap, a different visual for us. When you look at military history, 78% of the victims owned their firearm. When you look at the older population, 78% were owned by the victim, owned their firearm. But when you look at somebody who is 65 years of older and has a military history, 83% own their firearm. And there's definitely some limitations here. We definitely need to look more into perspectives by race and by sex and any other groupings that are of interest or demographics that are of interest. We weren't able to look at everything. We just tried to look at the most prevalent circumstances. We're not able to dive into Hispanic ethnicity and homelessness because there are small numbers in those categories, even though they would be of great interest. And something that we've been working on as the data set, I know Mandy talked about like how robust our data are and how much information is contained within them. And, the availability of our data sources are excellent. It's not perfect complete list. We're never going to know the entirety of everybody's circumstances. There's just not a data system to collect everything that's going on in everyone's life. So we did just recently add in EMS data as another source, so which helps more on our overdose side of data collection. But it is available to us to include in our data set, which helps us round out the picture even more. And I like to add this question, you know, these are different perspectives for these data, and we do have difficulty with small numbers, but I'm hoping that these groupings and this kind of perspective is helpful and useful for targeting interventions. If it's not, or you want to see something else, I'm always open to trying to understand what needs there are that need to be met in terms of data reporting. So very open to that as a point of discussion. And we can send out the slide deck to the group as well, but so you have all the information, contact information. So that is that slide deck. I'm going to stop that share. So I don't know if we want to pause for a second, if anybody has any thoughts or questions.
We did have a question on who owned the other firearms, and I just wanted to say that I believe that our data reflects the information that we have, so we will endorse unknown if we don't know who owns it. So that number could be higher of the percentage. It's just the data that's available to us from our data sources. We don't get the ATF reports or anything like that. We're basing this information on what is available in the law enforcement and the medical examiner data for that. I can say, as somebody who does this all the time, and I look at the data anecdotally, we do see, you know, there is access, you know, sometimes it's in the house and it might be owned by a spouse or a parent or a child. There, you know, it's normally either going to be unknown or it's going to be owned by somebody in the house. Very rarely, unless it is a homicide, do we see a weapon that was stolen that is used in terms of suicide. Normally the weapon, anecdotally, I can't, but you know, most of the times it is accessed within the home itself, or they've gone to purchase a weapon recently, which with our new laws that are just now where you just can't go and buy a handgun, we shall see, you know, where you're not able to go purchase firearms without a class and all this. Maybe, you know, that remains to be seen as to all of that. But anecdotally, I have seen folks who've gone to a gun shop and purchased a weapon and then utilized it within a short amount of time after that. So I do know. Oh, thanks for putting that in there. Oh, and happy about the permit to purchase. Thank you, Tracy. I appreciate that. But yeah, that's just wanted to put that out there that we do it. Some of them are going to be unknown. So, and a lot of the homicide, to be honest with you, is unknown. We do also collect data if anybody's interested. If it is a manufactured weapon, which is a polymer 80, aka a ghost gun, we do collect that information as well. If they're able to identify that, like I said, when we collect that data, we do collect that as well. Not a lot of them, but I'm sure it's going to come up more as we have these things more interested. So.
We agree with Tracy. We're drooling over here. This is wonderful data you folks have collected, man, and the way you approached it is just great. We'll be in touch offline. We'd love to chat with you some about this stuff. This is just really cool stuff. And yeah, part of the reason I brought up the unknown, you were asking about interventions. I know the state is working on the emergency resource protection order, the ERPO orders, the emergency protection orders. And so guns owned by other people in the house could kind of tie into some of that stuff that's just coming out in Delaware. So go ahead.
Caroline, what were you going to say?
I was just going to say that's awesome feedback and really interesting question. And I think as we start working on our suicide infographic, that focused dissemination activity, I want to be able to include more information that will be really useful. So if that's a piece that we can dive into, Mandy, and try to find a unique or a visually appealing way to present that, I think we should do that. And I also want to say mapping might be a piece of that future infographics, which might help us a little bit. If we can share that type of data, we will try to include it.
Ooh. Now just totally morbid curiosity. How many manufactured guns are people turning up in Delaware in these instances?
The ghost guns, the polymer 80s.
Yeah.
For suicide, anecdotally, just because
Yeah.
I look at the data a lot. Anecdotally, I don't see the polymer 80s used as much in suicide, more frequently identified in homicides.
Right.
But you know, it's hard to say with the homicide because they identify, because you can, you know, you're looking at casings, but some people jam the wrong casings in the firearm, so it's a whole thing. But I know I've seen more polymer 80 kind of descriptors in the police reports for homicides over the 7 years that I've been doing this. 8 years. Oh my gosh, 8 years. Oh gosh, 8 years that I've been doing this than I have in suicides. It seems to be a lot more common from my anecdotal perspective in homicide, but it's not even a number that you know, if you were to ask me makes and models, I see way more, you know, other makes and models being used in suicide than I do the polymer 80s. There's a lot more different firearms that are used more readily that I think people have access to. But once again, it's access, it's age, it's owning the weapon, it's all the, you know, it's all those sorts of things that go into having your, you know, that goes into all that. But I don't know about the polymer 80. Maybe it'll go up now that there's more stringent rules, where, you know, it remains to be seen how this is going to affect things moving forward. I do know Caroline has mentioned this before on several things, you know, at our NVDRS meeting, I believe it was Utah had a program where especially older gentlemen don't want their guns taken away, so they may not seek help. I know I have friends who are first responders who are less than enthusiastic about seeking mental health treatment because they're afraid they're going to lose their weapons. I believe it's Utah. They have a program where like your friend can take your guns for you. And it's like a dude, like a bromance.
Yep.
Go hold my guns for me while I go get myself fixed up. So I think that that's also something that has worked really well for them. So, you know, just as an aside of everything, as we're talking about firearms, I know Caroline's laughing at my use of bromance.
I felt that it seems appropriate. I liked where you're going with that.
We have
Ms. Murphy,
hands
I
up.
see your hand is up. Ms. Murphy, you want to go ahead?
Oh, I heard you say Miss Murphy, and I thought that can't be me because I'm just Tracy. So thank you for all of this incredible work and the assemblage of data, and the way you package it all up is so really, really helpful in guiding the work we do at the coalition, which is really about advancing policy to address and intervene and prevent firearm violence. And so I wanted to make one quick flag, which is that for the first time recently, Delaware data is starting to really mimic national data in terms of homicide versus suicide by firearm. And that is not because we're doing such a great job, you know, in any specific way, but we used to have, up until pretty recently, really disproportionately high rates of community violence. So it used to look like, oh, our suicide is only half of gun-related deaths in Delaware, so we must be doing really well on suicide prevention. Turns out, actually, no. We were just doing so poorly in community violence intervention that we were dragging the numbers to sort of favor homicide, right? I know it sounds like joyful and happy terminology when we're talking about this, and I appreciate the framing of these are real people. But I think what we can learn from the data, and something that we do a lot in our work, is take a look at what they're doing in other places and other states. And we have incredible data through Johns Hopkins that really compares state by state all specifically related to firearm violence. What's happening in Massachusetts, New Jersey, New York, Connecticut? What are they doing that we're not doing is our primary function, right? And so really, I just wanted to kind of come off mute and thank you for all of this incredible work. But also I wanted to flag that one of the reasons that the states like Massachusetts, New Jersey, New York, Connecticut have far better rates of suicide and homicide by firearm is because they have permit to purchase. And so I think it's going to be incredibly interesting over the next 3 or 4 years to really analyze the impacts of this specific policy on our rates of firearm violence, because for the first time, we're going to be able to regulate that access, which we talked about earlier. So anyway, quick, and please feel free to scroll up, and I'd love to see all of you join us at our fall forum, We're talking about protective orders, including the LVPO policy that Dan just mentioned. And so love to have you there.
I just want to say thank you, Tracy, for inviting us and everyone. But also, I did want to make some note about, I think you're talking about the CDC dashboard that is in collaboration with Johns Hopkins, and it shows, I believe, census tract level information as well. They do like, or maybe it's zip code aggregations. They do different aggregations to be able to show smaller data related to firearm violence rates. I don't know what the situation is going to be funding wise and how long that's going to be in play. But I am hoping to, we made a lot of great connections at that summit. So I'm hoping that Delaware has a future in better dashboarding, better data displays, and being able to have more readily available information. And then my second follow-up point is I really value being on this meeting so that I'm more aware of what's going on with the regulations and statutes. But I think it might be warranted to do an interrupted time study or time analysis with these data. So I think that if it affects our data, it will be important for us to include that. So I appreciate that as a evaluation type of.
Thank you, Carol.
Yep.
I want to see what, Bill, do you have a question? Bill Lynch?
I do, Sharon.
Okay.
I actually don't know if I'm able to share my screen. I don't know if I have access to that, or you can grant that to me, or MJ can.
Yes, sir. You should be able to, unless it's your vacation pictures from Hawaii, and I'll be very jealous. So don't show those.
That's not my vacation pictures from Hawaii. So, but I do
Okay.
have some of those pictures, but I won't show them to you today.
Thank you, sir. Thank you, sir. I'll be done.
So what I do want to share is actually for Carolyn and Mandy, and I appreciate your information today, but I'm also curious about if there's things you can actually look into for us, which would be very beneficial. So what we're asking about is the fact here that I don't know if you can see this here. Let me just bring it up for a second. So the reason with regards to suicide and also for homicide is that there's actually very interesting data looking at the fact that our suicides across the country are actually underestimated. So the reason I'm saying that is because when someone actually has an overdose death, you can't go back and ask them if it was intentional or it was accidental. So what's interesting here is that this looked at actually suicidal ideation from opiate use disorder. And what it showed you is cannabis use in particular, and men, like you've been saying with a number of the data that you guys also presented, is that regardless of frequency of use, cannabis had a 40% increase in odds of endorsing suicidal ideation. Now, the reason I bring that up is because I don't know if you're familiar with the next set of data, which actually is from Delaware. And this is actually from the annual report for forensic science, looking at fentanyl was the leading drug causing overdose deaths in Delaware the last 5 years running, which is not surprising. What is surprising, though, is that of those 5 years running, cannabinoids were second, testing positive in toxicology screens for decedents from suicide, above every other substance in the state. And the concern there is that is actually this masking certain suicides that did occur because of cannabis inducing that thought process, and that individuals who are struggling with opiate use disorder actually decided to actually commit suicide, and it was not an accidental overdose. So that's one thing to actually potentially look at. The other one that's actually very interesting, and I don't know, and I'm curious about, Mandy, when you look at violent deaths, is that what's interesting is that they've also shown in 2 states in particular, Texas and in Arizona, which is very interesting, looking at when individuals where a child was actually has died from neglect or abuse. The question becomes is, what substances were in those perpetrators of that violent behavior? And what's disturbing is out of the state of Texas, it shows you by far with a 2-fold greater rate, which is this slide here, with a 2-fold greater rate that marijuana was involved where a child has died from neglect or abuse. 84% of the time present in the perpetrator, or 107 times in their history, more than double any other substance being evaluated in the state of Texas. And I don't even know if Delaware looks at that. If they should capture it. And then the other one is also shown here. It's the same thing with regards to the state of Arizona. And this is even the most recent data, 2024 data from Arizona. So the reason I'm bringing that up is because the concern here is that if for some reason a child should die from neglect or abuse in Delaware, and or even a domestic violence situation where someone should die from that having occurred, are we able to track and then see which substances are involved? And the reason being is with obviously recreational marijuana, medical marijuana, more involved in our situations here in the state of Delaware, it's important with regards to looking at that data. And I don't know if you're able to do that for us, acquire that for us. And I should identify that when Sharon has said it, but we're actually a advisory member of the TAC addiction, and I'm also a clinical pharmacist with Jefferson Health System. So that's my background when you're wondering where this informational request is coming from. But thank you for sharing that information. If you're able to trigger what needs to be done to look into that further, we'd greatly appreciate your help. So
So
thank you.
I can speak if if the person is still alive. So you're talking about the suspect. So if you have, so let's address the first thing, which is the cannabis being present in the toxicology of the deaths. So that slide that you brought up, that isn't necessarily cause of death. That's just presence of presence of that substance in the deaths. And that's all of the deaths. That's not just suicide deaths. And that's just not homicide deaths. That's every death, natural death, everything like that. So we're not able to really parse that out as to, and the other problem, as you know, because you are a pharmacist, is the metabolism and the presence of marijuana in the body is different than a lot of other drugs, and it can linger depending on your use and how often you use and all that sort of thing. So that presence of marijuana, you know, you could have smoked last week, you could have smoked. So it depends. You would have to really look at those metabolites on GCMS and look at, like, are you looking at a Delta 9? Are you looking at 9/11? Are you looking at carboxy THC? You're really going to have to dive into those sorts of things. And that would be best suited to look at with the ME's office, because they can better speak, the toxicologist there could better speak as to what metabolites you want to look at and all those sorts of things. And if you're looking for a synergistic effect with opiate use disorder, we do capture if the person has a history of substance use disorder. We do not parse it out into opiate disorder, or we don't normally say there's no checkbox for opiate use. We may make a comment in the narrative, and you could word cloud search for all that, but the actual checkbox is for a history of substance use or a history of alcohol use, of alcohol abuse. So that's kind of to answer that sort of question. We don't necessarily collect that data or look at it in terms of it causing suicidality or somebody completing suicide based on that, because it would be hard pressed to determine when the person ingested the marijuana prior to that. But that's something that could be addressed better through the toxicologist at the ME's office, because they can probably speak to that and the veracity and the breakdown of all the chemicals. I would have to refresh myself on that because it's been a while since I've done that testing. For the children, we do not, if a child dies by neglect and they go to the ME's office, they have toxicology performed on them. And depending on the circumstances, they may also do toxicology on the breast milk, that if it's available, the formula that's there. It really depends on the circumstances and what the investigator sends in to look at. Do they pull tox on the suspect? That is not anything that we would see through the ME's office. That would be separate through the police department, and whether the police decide that they're going to send somebody for pulling for that testing. But that would require probably a separate set of legal circumstances and warrants and such in order to get that testing done, because you're not looking at them being under the influence of a drug, like a DUI case or anything like that. So that would be like that. We would have to look at that from like a legal standpoint, or making it so, you know, if you're being accused of this, they're going to pull tox on you at that time and do a drug screen. And to be honest, they would probably do that in the hospital. And the hospital is a urine test a lot of times, and then they would have to reflex it out if you wanted to get that breakdown of what chemicals are in it for marijuana in order to determine, you know, maybe a timeline of when they used, if you're looking at that marijuana use, because of the way it's broken down in the body. It's very difficult. And even from a urine standpoint, you could have somebody who may not even test positive at the time of the urine test, depending on when they used and everything like that. Because that's, I think the cutoff is 50, and somebody could run underneath that cutoff, and somebody might hit above it, and then you are going to have to set it out, of course, for reflex, if they even do all that testing. I don't know if that answers your question, but we don't collect that right now for suspect information. That's not something that would have to be worked on from more of a legal standpoint. And you know, from a regulatory or putting that in somehow, that if you do have somebody who's you know, that's how I see it from what I'm doing. I don't know, Caroline, have I misspoken or overspoken or anything?
No. And I think it's a fascinating topic that you brought up. And it definitely encourages me that, you know, we should dive into the data and see what's there on the topic. But I think it might be a lot of confounding situations that we would really have to dive into. Because I don't want to say pin it on marijuana entirely. I feel like there's probably a lot of other circumstances there that tie in. So to isolate marijuana as the only issue, or maybe just OUD, I have a hard time, you know, saying that is something that we would subscribe to. So I would like to see what our data provide on that, to just really be inquisitive about it and see what is going on in Delaware. But I think there's one other piece of this that we really haven't jumped into, and it's the non-fatal data. When it comes to testing, you know, we don't have any capacity to really add into what hospital screens are doing. We have the ability to passively ingest whatever information they can provide to us through our Essence data collection system. And we're pretty much out of time, I think. So I don't think I'm going to pull up those slides. Maybe that's for another time. But we have the ability to go through a litany of definitions in Essence. This past April or May, I want to say, I presented to the Delaware Coalition for Injury Prevention and presented like over 100 slides of different definitions, including, I believe, child abuse and neglect is one definition in there. Marijuana is one of the definitions. So there's ways of pulling data from syndrome definitions to look at what's going on very generically at a higher level. That data is not really meant for research and those kinds of things. There's still a lot of, I guess you want to say, preliminary status to those data. They're not confirmed. Like I said, we're passively getting that information. We're not verifying it. Oh, we have a few minutes. Okay, so I am going to pull this up.
And Carol and Mandy, I appreciate your responses. What's interesting to me, though, is that there are templates from Texas and Arizona that could be followed with regards to looking at some of that information. So I appreciate your willingness to look into that further, and we appreciate your information today and your help with that. So thank you.
Yeah, absolutely. If you have the ability to send those slides in or that reference information, I would be very interested in the template to see how they went about it. I would be very curious. I'm just trying to figure out what I'm doing right now. Okay, slide share. So this, I'm going to try to do this super quickly. So these are emergency visit data from Essence, which is, like I said, a passive data collection system from 100% of all of the hospitals in Delaware. The benefit of this data is that we get more timeliness. We get to understand what's going on, get a pulse of different conditions, but there is at the sacrifice of data quality. A lot of times we don't include significance testing, although we're working on adding that in. A few of these other items I'm not going to dive into. I don't provide rates for any visits that total fewer than 20, because those rates are considered to be unstable. We aren't allowed to show zip codes with populations fewer than 2,500 people or any geographic area, but I believe there's 4 zip codes that we don't show because of this. And we do get to show non-zeros, but if there's anything between 1 and 10, when the population is under 20,000, we don't show that as well. And just to show you the impact of COVID, there was a little bit of a dropout, which can inflate some of the rates in 2020, but we have kind of returned back to normal. So one of the definitions that CDC has developed is for suicidal ideation. This is a breakdown by age groups, and the dotted line for Delaware is the same across all of, so the Delaware line is suicidal ideation for Delaware, are all age groups, and it's the same for all the different category breakdowns I'm going to show you. But the lines that are above Delaware, the Delaware line, are mostly younger groups, and the ones below it are mostly older groups, older age groups. Suicidal ideation is more frequent and more common in males, and we do see a little bit of shift from the suicidal ideation grouping for Black or African American that was lower than the Delaware rate and the white rate, but it's starting to rise above what is going on in the white population and in the other and Asian rates. We see higher rates in Newcastle County. And this is, on the left, you have the counts. Sorry, on the left, you have the rates. So you can see the distribution throughout the state and how the zip codes compare to each other. And on the right, you can see the counts for suicidal ideation and where counts are highest. The next definition is suicide attempt. And you can see that the 11 to 24-year-old age groups are slightly higher than the rest of the population. These are smaller numbers though, so we do have more suppression applied to these slides. And the suicide attempt category is higher in females. The white population has higher rates than Black or African American and other populations, other race populations. There's not as much notable difference between the different county of residence. And here you can see the suicide attempt rate. It's kind of notable that the rate looks a little bit higher in, I think that's Long Neck, and in Dover and Central Delaware, and further into Newark. And I guess it's not totally Wilmington. I'm trying to think of what those zip codes are. But then when you get to see the counts, you get a little bit more information since the numbers are smaller. And that was just like a super quick look at how I typically present those kind of non-field data definitions. We do have a whole lot more. There's some on firearm violence as well. We have a hard time differentiating between intentional firearm and non-intentional. I'm trying to think of what other firearm. There's a youth violence definition. We have intimate partner violence definition, sexual violence. So there's a litany of things that we can be looking at that might be helping us understand different circumstances and different areas that we need to focus on. But that's just a brief taste of it from the suicide perspective. So I wanted to be able to share those today. So I'm glad we got to.
Thank you. Ms. Judd, Ms. Bundick, I so appreciate, I want to be mindful of folks' time. I so appreciate you bringing this data conversation to us. And, for me, the great part about the SEOW is, one, we get to nerd out on data, right? We get to talk about the implication of data, how we can use data for prevention and planning and, really change people's lives, and then also understand people's experiences more robustly. I think, what your data confirms, or not your data, but what the data confirms is that we really can't say with substance use, mental health, suicide, chicken, egg, right? And so when we apply these strategies and interventions, we can make differences across the different concentric and overlapping circles of people's behavioral health experience. If we could, round of applause or silent clap for our presenters, I really appreciate them coming and talking with us. I will make sure that all the information goes out after the fact, that, if folks have things in the chat or our presenters have something. The two things that I do want to mention outside of this is that there is a webinar for the Central East region on November 18th called Adolescent Suicide, Non-Suicidal Self-Injury and Substance Use Disorder that kind of looks at the different intersections of those things. So we'll send out the link. It's not us, it's the Central East PTTC, but it gets into some of that overlap from a clinical perspective, but also from a data perspective. So I encourage people to take a look at that. SAMHSA also had a 2025 Suicide Prevention Awareness Month Toolkit. And then finally, the availability of 988, right? So our partners at DSAM are leading that effort, but I do want to make sure that everyone on this call knows about 988, but also, share the word, put it out there, because suicide is preventable, and we want to make sure that people know that help is available. There is hope. So please use those things. That'll be in our slides when we send them out. I thank everyone. We're right at 11:30, so I thank you for that. I thank everyone for their time. If there's anything you want to stay on, feel free to chat with me, or my emails in the chat. Otherwise, have a great day, everyone, and I still appreciate y'all coming in and talking to us today.
Absolutely. Thank you for having us.
Yes, thanks so much. Everybody be safe out there.
And Mandy and Carolyn, that information is in the chat, the 4 links.
Thank you
Thank
so
you.
much.
Thank you.